Okay, so this lecture is going to cover an introduction to emphysema, asthma, and chronic bronchitis. Um, all of these diseases are very multifactorial in etiology, and so I do stress that this is a introduction to those disease processes and are just meant to get for you to get familiar with what the diseases are. So the first thing that we're going to cover in this lecture is emphysema. We're going to go over the pathogenesis and some of the mechanisms behind emphysema. The pathophysiological alterations that can occur with emphysema, such as alterations in mucus production, changes in parasympathetic tone, and so on and so forth. We're going to cover the different classifications of emphysema. Then we'll move on to patient presentation, what X-rays typically appear like, and then precipitating factors as well as the treatment. Then we're going to cover similar things with asthma, and then we're going to finish up with a overview of chronic bronchitis. And again, as I just mentioned in the previous slide, this is an introduction to all of these diseases. So what is emphysema? Emphysema is typically characterized by some sort of airflow limitation due to alveolar destruction and enlargement. And so within this disease process, what typically happens is there's some sort of breakdown in the elasticity of the alveoli, and there's actually a little bit of breakdown of some of the alveolar walls, and due to necrosis or apoptosis, and that causes them to become enlarged, and they're sort of also quote-unquote floppy, if I can use that terminology. And oftentimes occurs because of an imbalance between proteases and antiproteases. And so these proteases, what they do is they break down collagen and elastic fibers, and if they do so and they do so unchecked, then that results in a decrease in the sort of capacity of the alveoli to maintain its patency, but also its ability to recoil. So oftentimes this disease is characterized by increase in FEV1 to the FVC ratio. The antiproteases, what they do is they actually cleave proteases. So proteases are responsible for the destruction of the alveolar tissue, and the antiproteases destroy the proteases from destroying the tissue. And so this sort of lung remodeling, in essence, is really due to a balance between antiprotease activity and protease activity, with the antiproteases preventing the sort of alveolar destruction that occurs in emphysema. Within this alveolar destruction, it also can occur because of alterations in macrophage and neutrophil activity. Now, both macrophages and neutrophils are important for lung physiology, in the sense that there's a percentage of macrophages that are actually always monitoring the alveolar walls for foreign particles and whatnot that happen to make it down to the alveolar structures. And when they find a particle that happens to make it down to alveolar level, the macrophages phagocytize those foreign particles and help to remove that from the lungs. However, if they become activated in a sort of more pro-inflammatory, more pathogenic way, then they can secrete additional inflammatory cytokines that can create a bit more of an imbalance between these proteases and antiproteases, such that there's a little bit more inflammation and inhibition of antiprotease activity, leading to a lot of lung remodeling. As I mentioned, there's enhanced alveolar wall cell death and a reduction of the alveolar wall maintenance. And so what this indicates is that there's a lot of alveoli that in a normal lung would exist as patent individual discrete structures and discrete architecture within the lungs. But when the walls of the alveoli go through apoptosis, which is a form of cell death, then that alveoli actually sort of sums with neighboring alveoli to become much larger. So not only is there a change in the actual elasticity of the lung, but there's actually a change in the number of alveoli as well, such that there's summation of individual alveoli to make larger alveoli, which further contributes to flow limitations that are observed in emphysema. There's also a higher level of chronic inflammation and oxidative stress, and those tend to enhance lung destruction and impair lung maintenance and repair mechanisms that are at play. So, again, chronic inflammation could be because of macrophage activity. Could also be because of your innate immune system actually secreting inflammatory cytokines, and those inflammatory cytokines then break down this relationship between antiprotease and protease activity, such that there's enhanced protease activity and a little bit more alveolar destruction. Now, we consider oxidative stress. High levels of FiO2 can cause, radical oxygen species, ROS production, and can sort of play into this oxidative stress sort of environment. And so if you give someone very high levels of FiO2, then over a long period of time, that can actually cause a damaging effect on the overall alveolar physiology. Then the other thing that's accompanied by emphysema is surfactant instability. There's a lot of malnutrition that's associated with emphysema, and cellular apoptosis. They're all etiologies of the disease. And cellular apoptosis, as I mentioned, correlates with alveolar wall cell death and the reduction of the number of alveoli. Now we talk about surfactant, and we're going to talk about it again here in a couple of slides, but it's really important to understand that the regulation of surfactant is absolutely essential for lung physiology, and it's not only important for maintaining alveolar patency, but it's also important as an anti-inflammatory molecule, and it's involved in actually fighting infections, and is actually involved in the innate immune system. And so if somebody experiences a reduction in surfactant production and or the way that surfactant molecule combines together, and if it sort of combines in such a way or aggregates in such a way that is pathogenic, then it can also contribute to the disease phenotype, because at that point, if there's lack of surfactant production or it's not in an available form, then it can create an anti-inflammatory environment that's important for alveolar maintenance. Now, within this slide, you see this picture here, and in this picture, tobacco or smoking is a major cause, pathogenic trigger of emphysema. And it's true that smoking of any kind, any type of smoke, can lead to the generation of emphysema, the pathophysiology of emphysema. It does so a bit more insidiously over a long period of time. But I want people to also understand that just because somebody smokes doesn't mean that they are going to get emphysema. And just because somebody has emphysema does not mean that they absolutely smoked. Because there are a lot of people that have emphysema that didn't smoke, and a lot of people that don't have emphysema who actually do smoke. But nonetheless, we'll talk about tobacco smoke and smoking in the context of the slide. And what ends up happening is tobacco smoke has nicotine in it that recruits a lot of macrophage and neutrophils to the local area, the local lung area. And this production of radical oxygen species, or these free radicals, which are highly reactive molecules that have a free electron on them, and so they're very highly reactive with neighboring tissue. That leads to the production of inflammatory cytokines, such as IL-8 or TNF-alpha, that also facilitates the recruitment of macrophages to a local area. Now, these guys are produced, these inflammatory cytokines are produced by your innate immune system. Your innate immune system is really anything that can cause the production of an inflammatory cytokine. And basically all of your cells produce inflammatory cytokines. The innate immune system, is defined as an immune response that all of your cells have, that's independent of the pathogen. So it doesn't have to be taught what the pathogen is, it just automatically responds. And oftentimes it does so through the secretion of these inflammatory cytokines, which recruit macrophages to the local area to help mitigate that pathogen in that local area. Now, when this in addition to recruiting macrophages through the activation of, or the secretion of local inflammatory cytokines. There's also inactivation of antiproteases via tobacco smoke and via exposure to these radical oxygen species. When these are inactivated, then what happens is that there's a greater amount of elastase destruction. Now, neutrophils, when they come into that area, again, being hyperactivated now can contribute to that elastase destruction, and can also contribute to the pro-inflammatory environment of that area. Now, in addition to environmental factors, there are also congenital reasons why somebody might have breakdown of their antiprotease activity. And so if somebody has alpha-1 antitrypsin deficiency, i.e. they don't express the gene alpha-1 antitrypsin, then alpha-1 antitrypsin is the antiprotease for trypsin, which is a protease. And if there's then unchecked trypsin activity, then that'll that'll additionally lead to lung damage and lung breakdown. So there's an overall cartoon of that. Typically, people that have alpha-1 antitrypsin deficiency or some sort of genetic mutation that predisposes them to some type of breakdown in elasticity of their lung or emphysema, usually they present with the pathology at a much earlier age. So if you see anybody that's relatively younger that has emphysema, don't necessarily assume that's because of poor lifestyle. You have to also check for potential genetic causes of the disease as well. So this is a cartoon of what a normal alveoli looks like in an alveolar sac, and then this would be a drawing or a picture of alveoli with emphysema. And I think that this very nicely illustrates the point of the differences between the architecture of a normal alveoli and an alveolar sac with that's undergone pathological changes that are consistent of emphysema. And so in the normal alveoli, you can see that there's some very nice architecture of each individual alveolar structure, such that there's each alveoli has a very patent and defined discrete air space, and they're separated from each other by pores of Kohn, which allows communication between alveoli. There's a lot of interesting information about pores of Kohn that I encourage you guys to look up. Now, in the case of emphysema, where the alveoli has lost much of its elasticity, we can see that there is, in the case of these alveoli right here, there's actually been a breakdown of this alveolar wall. You can see right here, and therefore this alveoli has summated with neighboring alveoli to make this overall alveolar airspace much greater. But there's also a lack of patency, and there isn't the same discrete architecture that separates one alveoli from the next one. So if I can use the term, quote unquote, flobby, I think that would heavily describe this. And the local lung parenchyma that surrounds this alveoli has lost its overall patency and elasticity, which also contributes to an airflow limitation that a lot of people with emphysema experience. And so you can see that this overall airspace here is actually larger for two reasons. One is that there's loss of alveolar patency around the walls of this alveoli, but the second reason is that there's been apoptosis that's occurred, or programmed cell death, that's actually caused a breakdown of the alveolar wall right here. It causes these two alveoli to summate. So these alveoli are heavily damaged. And again, there's a heavy airflow limitation because of both the alveolar wall destruction, but also because of the summation of those alveoli together. Now, in addition to these direct alveolar changes, there are also changes between the distance of the capillary membrane, such that people that have emphysema oftentimes have a greater capillary alveolar distance, right? So there's a less association between those capillary alveolar membranes, and so, and also in the context of a ventilation type of issue, some people might also present with some oxygenation abnormalities as well. However, the predominant disease process is typically a ventilation type of issue. There are some environmental factors and some risk factors that are associated with the disease. Environmental factors would be occupation, chronic exposure to dust, fumes, and gases are believed to be associated with onset, and I put COPD in quotes up here. I'd really prefer that people discuss the term emphysema instead of this term in many patients. Now the extent of the emphysema with exposure oftentimes depends on the overall length of the environmental exposure and also the severity of the exposure. Such that very hot, severe environmental exposures can create lung destruction, but also low exposures over very long periods of time can sort of acidiously cause a breakdown in that antitrypsin um, um, association or regulation that can lead to changes in lung morphology and emphysema. The amount of cigarettes that people smoke, that consume per day. Most people in the clinical setting, think everybody that smokes gets emphysema, but that's not always true. It turns out that about 15% of smokers do not get emphysema, so not all smokers get emphysema. But 80 to 90% of emphysema patients are smokers. It was also, within this number is suggests that because not all emphysema patients are smokers, that not everybody who has emphysema smoked. There's some malnutrition and starvation risk factors associated with emphysema, such that people that have anorexia nervosa have a decreased diffusion capacity, increased risk of emphysema on CT scan. And I think an important take-home message of this statement is that your metabolism heavily relies on your nutritional status and your overall caloric intake. And so, as long as people are meeting their nutritional status, remember that surfactant is a molecule that's produced and secreted, and the reliance on fatty acid transport and overall metabolism, systemic body metabolism, is really important for surfactant production, such that albumin transports fatty acids to the alveolar sacs and the type 1, type 2 pneumocytes. And if that were to not happen, then there would potentially be a reduction in surfactant production because of reduced fatty acid transport to the alveoli. And then lipid metabolism. This sort of piggybacks on this idea of malnutrition and starvation. That is, that blockage of lipid metabolism tends to increase neutrophil macrophage activity in the lungs, also increases inflammatory cytokines productions, as well as reduces the amount of surfactant that's produced. Now emphysema itself and the pathogenesis of it is enhanced following a reduction of surfactant proteins, A, C, and D more specifically. Remember that there's 4 surfactant proteins. And part of the reason why this occurs and why there's this association is because, again, that surfactants are also anti-inflammatory and are also involved in your innate immune system. And so without them, then there's additional inflammatory processes that occur in the lungs and additional alveolar destruction that could potentially occur. And again, just to reiterate, this is a cartoon then of a normal alveoli with normal alveolar architecture, and then an alveolar sac that's been heavily damaged, including the terminal bronchial tree here. And you can see that there's heavily impaired airflow, such that this alveolar sac has a pretty severe airflow limitation. So oftentimes people that have emphysema have chronic hypercapnia. Okay. There's a genetic component to it, so it would be alpha-1 antitrypsin deficiency. Again, as I mentioned in a couple slides ago, and that would be if somebody has a deficiency in the antitrypsin activity. Antitrypsin inhibits the protease trypsin, and so that would mean that there's sort of unopposed neutrophil elastase activity and unopposed trypsin activity, which would break down the integrity of the alveolar wall. Usually, if somebody has a genetic component to emphysema, and and if they have alpha-1 antitrypsin, that usually presents within the fourth or fifth decade of life. So usually within 45 years old. Um, so if you see somebody with emphysema that's 45 or less, then it's a good idea to check for genetic causes of the disease. I think it's also important to note that people that have alpha-1 antitrypsin deficiency have systemic alpha-1 antitrypsin deficiency. It's not only the lungs that are affected, such that the liver is also affected. In fact, liver dysfunction predominates the clinical symptoms in the early phases of the disease etiology for these people. And so you'd expect to see these people have a higher proportion of, of, of jaundice presentation if their biliary tree is blocked, or if there's some sort of blockage of bilirubin removal from the bloodstream. Then there's also several connective tissue disorders, Cutis laxa, Marfan syndrome, and Ehlers-Danlos syndrome, and these are just a group of connective tissue disorders that are also associated with the onset of emphysema. And again, these have a very early onset of age. And so in this picture, what this represents is alpha-1 antitrypsin inhibiting lung elastases, inhibiting proteases, and that smoking activates them. But without alpha-1 antitrypsin, then trypsin, which is protease or elastase, is then free to create additional alveolar destruction, unchecked alveolar destruction, if I can use that terminology. And so here's another overview slide of the pathogenesis of emphysema. Again, we're going to use cigarette smoking as a causative factor, even though, as I mentioned several times already, that there are several environmental factors associated with emphysema, and not everybody who smokes gets emphysema. But nonetheless, there's some sort of environmental exposure that causes secretion of proliferation markers like TGF beta, EGF, and PDGF. These are all growth factors that contribute to area remodeling. And what exactly happens in that remodeling? Well, there's increase in bronchial fibrosis, smooth muscle cell hypertrophy, there's mucus hyperplasia, and there's epithelial thickening that oftentimes occurs downstream of these growth factors that are secreted by the airway epithelium. And so these anatomical changes sort of set the stage for reactive disease pathology, which when stimulated, can further create an obstruction to airflow. There. Independently of that, there's activation of macrophages that again secrete pro-inflammatory cytokines, and these recruit additional neutrophils and CD8 lymphocytes that then come together to cause additional elastic fiber damage. Now, both of these are involved in your innate immune system, and so they're a bit of a double-edged sword, because under non-pathogenic conditions or under the right environmental stimuli, they're actually somewhat healthy for you. But under pathogenic and pro-oxidative, pro-inflammatory environment, they actually become a bit more pathogenic. So when there's this elastic fiber damage, then that contributes to alveolar wall breakdown and emphysema and further airflow obstruction. Now, as I mentioned in previous slides, but there are genetic components of changes in the airway epithelium, but also elastic fiber damage, and there's also epigenetic components. So epigenetics means that there's gene regulation that occurs that's independent of the DNA sequence, and so in this case, there's an environmental stimuli, more than likely that could cause epigenetic changes in your overall structure of your chromosomes, such that there's silencing of genes that are involved in preventing this type of lung remodeling, and activation of genes that are involved in actually remodeling those alveoli. Now, there are three different classifications of emphysema. Sensory lobar emphysema. This is oftentimes is the most common times its most common kind. It's oftentimes the result of an environmental exposure, and in this case, the emphysema predominantly initiates and occurs um, around the proximal bronchioles. Okay, and the reason why this is typically more environmental is because as somebody inhales, the 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 overall concentration of that environmental exposure decreases as you propagate through the terminal structures of the lung. And so I like to relate this to radiation exposure. Somebody's standing very close to a radiation source and they get a very high dose, but as they move further away from that radiation dose, and they experience a much lower dose. And so if you can take that same sort of principle and apply it to this type of classification of emphysema, then you can sort of sort out that the proximal bronchioles and alveolar structures in the proximal bronchi are more likely to be affected than the distal bronchi, which are more likely to be a bit more protected from environmental exposures. It's predominantly found in the superior lung regions as well. Then the next type of classification is called panlobar emphysema, and that's typically associated with alpha-1 antitrypsin deficiency. And this is sort of more uniform destruction of the alveolar lung tissue itself. Happens a bit more homogeneously throughout all the lung regions. So again, uniform destruction of the entire alveoli. Then paraseptal emphysema is usually involves destruction of the distal alveolar air structures, right? And so this, when these alveoli are summated or they undergo this remodeling or this reduction in elastase activity, then what can be created on the surface of the lung is called apical bullae, and they're just sort of little blebs that form in the lung, little regions of weak lung area that can predispose these people to spontaneous pneumothorax. Sometimes people sneeze, or there's a sudden increase in the amount of pressure in the alveoli, and sometimes that can cause a spontaneous pneumothorax, and usually that's why. Oftentimes with this type of emphysema, the airflow limitation is not as robust, and so a lot of times the airflow is preserved, probably because it involves the distal airway structure as opposed to the entire lung region or the proximal airway structures. So here's a gross anatomical pictures of lungs that contain emphysema, and so you can see that there are these gross anatomical changes within the lung. You can see there's destruction of alveolar tissue here, all right, and you can see on the surface of the lung these will be the weakened airway structures of the bullae. And then you can see these anatomical changes here that would be associated with enhanced lung inflammation, and again summation of the alveolar structures. You see the bronchial trees that propagate throughout the lung here, along here. You can also see, for example, in this lung, you can see these very large regions of destruction here that are consistent with emphysema changes, right? Something I want you guys to take note of is that these alterations in lung morphology and pathophysiology don't occur uniformly, and so a lot of people have this perception that pathologies in the lungs happen uniformly, but they don't. There's actually small microclimates within the lungs, and therefore the lungs don't have the exact same compliance throughout them. In fact, individual regions have slightly different levels of compliance. I think that's important for you guys to take note of. Okay. So if you were to give somebody a med-neb treatment, the majority of the drug is going to go to the heavily ventilated regions and not to the hypoventilated regions. And so sometimes it takes a little bit of time for a drug to be propagated to those individual lung areas. If you put somebody on positive pressure ventilation, and somebody's going to, the alveolar sacs that experience the most trauma are going to be those that have the greatest compliance. Yeah. and the regions that are going to experience the least amount of pressure are going to be the ones that have the least amount of compliance. And so sometimes you have to be careful when you place people on a ventilator because it's easy to cause barotrauma in some circumstances. Typically, when people have emphysema, their presentation can range from being having a normal appearance to a very labored appearance with multiple signs and symptoms, and that just depends upon the severity and the progression of the disease. But typically, people that have emphysema present with tachypnea and dyspnea upon mild exertion. Now, it's normal for individual people to become a bit more winded upon exertion. It's just that people with emphysema have a greater amount of tachypnea and dyspnea for a certain level of exertion. And part of it's because of the airflow limitations that these people experience. They don't have what I would refer to as quote unquote the same cardiopulmonary reserve that a normal person would has, and so they can't dip into their expiratory reserve volume as well as somebody can that has a normal lung physiology. And so therefore it's much more difficult for them to deal with certain cardiopulmonary insults or certain insults that result in enhanced CO2 production. It's hard for them to change their ventilation of their distal alveolar spaces. They often have a respiratory rate that increases proportionally to disease progression and or severity. And again, that's because as the disease progression continues, again, there's a loss of the use of their expiratory reserve volume, but also there's a more enhanced airflow limitation, and that means additional hypercapnia that the person has to deal with. As the disease progresses, there's a 2-to-1 increase in the AP diameter. It's called barrel-chested. So if you see this guy sitting in this chair, this guy has what's called a barrel chest appearance. Sometimes these people present with cyanosis, again depending on the severity of the disease process. A limb musculature atrophy typically occurs. Some people explain this to be because of an increase in accessory muscle use to actually force exhalation, again with emphysema being defined by increase in FEV1 to FVC ratio. But the reality is that we know that there are pretty profound metabolic changes that occur in these people, and those pretty profound metabolic changes also contribute to muscle wasting, and there's changes in your metabolism such that things like the citric acid cycle become more difficult, and there's also a more difficult production of ATP. And so, as I mentioned, there's pretty significant metabolic remodeling that occurs in these people that I think you have to think about. Oftentimes, or some people will present with peripheral edema secondary to pulmonary hypertension, because as the alveoli remodel and as the lung remodels, there's an increase in pulmonary hypertension. That pulmonary hypertension creates a greater workload on the right ventricle, and as that right ventricle then begins to remodel, it can begin to fail for various reasons. And when it fails, and there's sort of a fluid, enhanced fluid in the systemic vasculature, such that people present with pedal edema, jugular venous distension, hepatomegaly, and so on and so forth. Right to left shunting because of again alveolar destruction, JVD, right heart failure. I just talked about that. It could be diffuse or focal root wheezing throughout individual lung fields because of potential for smooth muscle cell remodeling, but also because of alterations in mucus production, enhanced mucus production. Diminished breath sounds, hyperresonant, prolonged expiration, hyperlucency on a chest x-ray, and again, barrel-chestedness. We've already discussed. Okay. Now, on a chest x-ray, on the left here, you see a chest x-ray of somebody with emphysema, and on the right, you see a normal chest x-ray. You see that there are pretty profound alterations that occur, such that a person that has emphysema is actually an increase in hyperlucency of those lung fields relative to a normal lung. right? But also there's enlargement of the right ventricle in this case. Again, that suggests there's an increase in pulmonary vascular resistance and increased pulmonary artery pressure. There's oftentimes there's increase in intercostal spacing, and I give you the centimeter markings of normal, and there's actually increased intercostal spacing. It's usually accompanied by flattened hemidiaphragms. So if somebody's constantly hyperinflated, then there's a bit more flattening of the hemidiaphragms again, and that reduces the expiratory reserve volume that that person can actually generate. Okay. So some diaphragmatic adaptations that occur. The individual components of contraction, or the function of the diaphragm, would be the contractile force and the endurance. These can be independently measured, especially the contractile force, by negative inspiratory force, or NIF. And what happens is hyperinflation typically induces a diaphragmatic shortening, which can already take away from the contractile force that somebody can generate. So there's also a fiber shift from type 1 oxidative fibers, which might be considered beneficial to meet the workload and enhanced endurance capacity, but they have less contractile force. So these are kind of similar to a marathon runner. So they're not set up to deal with a sudden fast insult, but they're more set up to be similar to a marathon long distance runner. And so again, if somebody were, if a person with emphysema were to experience a sudden onset of some sort of inflammatory related condition, or something that would increase CO2 production acutely, then they might present with more respiratory distress relative to a normal person for a number of reasons, but one of those reasons is also because of a shift in type 1 oxidative fibers. We also know that the diaphragm, being directly adjacent to the lung, in fact almost touching it, just separated by a very small layer of synovial fluid, is subjected to oxidative stress and sarcoplasmic injury because of an oxidative or inflammatory environment of the lungs. So then there's a little bit of actual wasting of that capacity of that diaphragm to be able to generate a force. So all these play an important role in the onset of dyspnea and weaning from the mechanical ventilation, and so on and so forth. Now, the shortness of breath associated with emphysema, a lot of times these people with a decreased quote-unquote cardiopulmonary reserve, is what I would call it, if they're exposed to a virus or some sort of antigen that causes an allergic reaction or some sort of immune response, or something that further activates cholinergic signaling, these people that have emphysema already have enhanced cholinergic signaling, and so they have a propensity to develop a bronchoconstriction, and they have a propensity to increase mucus production, but those tend to activate them even more. And when that becomes activated, sometimes it's difficult to turn off in people that have emphysema, and that can lead to prolonged symptom recovery. But also, if there's like I said, a change in metabolic activity, such as there's an increase in CO2 reductions, then these people are not adapted very well to be able to deal with that sudden onset of CO2 productions, and so they're not able to increase their alveolar ventilation to be able to accommodate that increased CO2 productions, to be able to maintain blood pH as well. And so they're more likely to present with respiratory distress. Viral initiated episodes are thought to make up about 40% of the cases of difficulty breathing in people that have emphysema. And viruses can trigger also the majority of asthmatic exacerbations. About 50% of them in adults are because of some sort of virus. For the bronchoconstriction in asthma, if you give somebody a beta-2 agonist bronchodilator and an anticholinergic, usually you can be successful at reversing that. The same thing doesn't occur if somebody has emphysema or some sort of antigen, there's a little bit less success at reversing that because there's the component of increased CO2 productions as well in those patients. Okay. So treatment for emphysema, somebody presents with a respiratory distress, we obviously want to deal with the enhanced parasympathetic tone that accompanies emphysema. And so you give an anticholinergic therapy, as an Atrovent, as well as a beta-2 agonist to activate the beta-2 receptors, and so it'd be albuterol, levobuterol. There's other chronic bronchodilators that somebody can be on that are a bit more long-acting. There's also combined medications that combine a beta-2 agonist and anticholinergic together that can be used. So, and some people you need to use supplemental oxygen only if they need it. And exercise and physical therapy is really important for treating these people. Again, because they have alterations in their metabolism and metabolic function, and exercise seems to be somewhat good at addressing those alterations in metabolism that occur. I want to deal with mucus production as well. Again, these people have enhanced parasympathetic tones, so that can obviously accompany increased mucus production. Now, when I say that, you have to be careful about the risk of bronchoconstriction, especially with medicinal medications. And so here in these people, they have a propensity to have enhanced bronchoconstriction because of smooth muscle cell remodeling or increase in parasympathetic tone. And therefore, if you go and give somebody Mucomist, for example, or even hypertonic saline that's known to cause bronchoconstriction, well, that's probably not a good idea in somebody that already has a propensity to develop bronchoconstriction. And so you have to heavily weigh the risk versus gain of giving something like that. You can also try, somebody has enhanced mucus production, they have emphysema. You can also try other types of mechanical therapy such as CPT that might be able to address the issue. Okay, so that was emphysema. Now we're going to move on to asthma and the pathogenesis of asthma. And so first of all, we're going to define asthma. I have a cartoon representation here to be able to walk through that. So this is an example of a normal airway in which there's the lumina of the individual bronchi, followed by the bronchial epithelium, and then there's an underlying smooth muscle cell layer. Now, if somebody has asthma, what asthma is a chronic smooth muscle cell remodeling process, such that there's hypertrophy and hyperplasia of those smooth muscle cells. Yeah, so they're hypertrophied, but they're also increased in number, such that there's a decrease in the overall diameter of this bronchial tree here, its overall bronchi. Now, if somebody then experiences some sort of stimulus within this bronchi that would cause bronchoconstriction, then because there's additional smooth muscle cells here, that oftentimes that constrictive stimuli is exaggerated, resulting in a very strong bronchoconstriction phenotype. And so it's important to note here that asthma is actually a smooth muscle cell remodeling process, and actually is a chronic remodeling process that takes time. And so you see all these kids that have reactive airway problems. Well, it doesn't necessarily mean that they have asthma, because they haven't had a chance to actually develop the smooth muscle cell remodeling that's associated with the disease process. So we need to heavily separate out a reactive airway problem, which would be something similar to allergies, and actual asthma. If you look at this is called H&E staining. So this is just staining of a bronchial section. And so if the bronchi was coming from the screen directly out towards you, this would be the bronchial epithelium right here. You can actually see some cilia on top of this epithelium. And then underlying, you can see this area here, that's a smooth muscle cell layer. So again, epithelium and smooth muscle. Now, when this becomes, when this hypertrophies, again, you can see there's quite a lot of hypertrophy of this epithelium, and also there's quite a bit of hypertrophy of this underlying smooth muscle cell layer. So you can see how thick this smooth muscle cell layer here looks compared to this region right here. when it becomes activated, or there's some sort of stimulus that that irritates that, it goes through what's called degranulation. And again, here you can see that there's even more gross anatomical changes that occur in epithelium that's become degranulated or activated, and then the underlying smooth muscle cell layer that's actually become activated, that would be undergoing a bronchoconstriction event. So asthma versus a reactive airway disease. I think this is an important component to understand. Most children under 3 years of age don't have asthma. In fact, only 30% of infants who wheeze develop asthma. So you have to remember that bronchoconstriction is a normal physiological response. It's when people have excessive bronchoconstrictive events, and we fail to deal with this reactive airway problem, that there's underlying smooth muscle cell hypertrophy and hyperplasia, resulting in a bit more smooth muscle cell remodeling and a exaggerated bronchoconstriction phenotype. So again, here I just put that point right here. So it is a chronic remodeling process, and it does take time. It takes several years. It doesn't happen in a day. So airway remodeling, I put a note here. Airway remodeling is the primary factor leading to smooth muscle hyperresponsiveness. It's also associated with edema and increased mucus production that goes along with asthma, as well as any other pathological disease that we discuss. So for a diagnosis of asthma, a person must be at least 5 years old, because they have to be old enough for smooth muscle cell to occur. They have to have recurring symptoms of airflow obstruction. They have to have a reversible flow obstruction with a bronchodilator, and it has to be at least 10% effective. If there isn't a reduction in airflow limitation from a bronchodilator, then the obstructive disease is something different. It's because of more elastic destruction of alveolar walls, or some changes in the actual bronchial diameter, called bronchiectasis, or there's something else going on that's causing an obstruction to airflow. And all alternative diagnoses have to be excluded. Okay, so this is important because you'll see a lot of people that are actually classified as having asthma, when the reality is that they don't really have a lot of smooth muscle cell remodeling. They just have a reactive airway problem. Okay, so here's a bit of the pathophysiology of asthma. And so what typically happens is so this is a cartoon, and on the left side of the screen would be the lumen of the bronchial tree. And there would be a mucus layer that's filled with things like DNA, bacteria, glycoproteins, and cell debris. Then just below that mucus layer, there's epithelial layer, and just below that epithelial layer, there's a smooth muscle cell layer. Now, what ends up happening is some sort of antigen comes in and binds to a mast cell and activates a mast cell. That causes this mast cell to degranulate. What's called. So you have mast cell activation and degranulation. That leads to histamine and protease release, and also cytokine release and leukotrienes. So you take an antihistamine, you're really trying to reverse this histamine effect here. All these together do several things. They lead to goblet cell hypertrophy, metaplasia, and enhanced mucus production. They cause airway hyperresponsiveness. They cause smooth muscle cell constriction. They recruit macrophages to the local area. Remember, inflammatory cytokines recruit macrophages to the local area. They cause airway inflammation that further contributes to bronchial narrowing, and they cause a mucosal edema that further contributes to bronchial narrowing. And an antibody called IgE is typically involved in this overall response, in terms of actually binding the antigen and then coupling that to a mast cell to lead to that mast cell activation. So each one of these steps right here is oftentimes targeted pharmacologically take an anti-IgE medication to get rid of these IgE antibodies that, again, couple this antigen to this mast cell to activate it. We have antihistamines, anti-inflammatories, things that deal with airway hyperresponsiveness like beta-2 agonists, and anticholinergics, so on and so forth. So people that have asthma, that have a patient presentation, have some sort of environmental exposure, have sudden onset shortness of breath, triggered by environmental exposure, and they have inspiratory and expiratory wheezing as a result of that. Some of them will present with pursed lip breathing, tripoding, sinus around the lips and nail beds. As symptoms progress, that'll lead to fatigue. Respiratory failure oftentimes ensues in severe cases, and are cases that are left untreated. So oftentimes what you'll see is an initial blood gas in which the pH is actually a little bit high because somebody is actually hyperventilating to reduce their amount of CO2. Now this is the time you want to initiate pharmacological interventions. Over time, this pH will actually normalize a little bit, and then as the person begins to tire, then the CO2 will begin to go up and the pH will begin to go down. Notice that the bicarb isn't changing because this is dealing with an acute setting. And so when the person begins to fail, then at some point, if they begin to tire too much, then that would be a time to consider mechanical ventilation. But anything before that, we should do everything that we possibly can to give bronchodilators, anticholinergic to these people to prevent them from actually tiring and failing, and keep them off the mechanical ventilator. Remember that there are quite a lot of risk factors associated with mechanical ventilation, and the best thing that we can do for these people is actually keep them off the ventilator to prevent additional mechanical ventilator-induced lung remodeling and so on and so forth. The treatment involves albuterol and Atrovent, some sort of anticholinergic, some sort of beta-2 agonist. And so this is a cartoon representation of a beta-2 receptor. It's called a G protein. So the exchange of GTP for GDP, and this G protein, when albuterol binds to adenylate cyclase, that causes a conformational change, and adenylate cyclase leads to conversion of ATP to cyclic AMP. This 3,5, it's called 3,5 cyclic AMP, is what has the effects on either phosphorylating myosin that causes smooth muscle cell relaxation. It also lowers intercellular calcium. It also causes inhibition of mast cells, which is really important. We consider mast cell degranulation as part of the pathogenesis of asthma. And then when it's broken down by phosphodiesterase into 5' AMP and degraded. So as long as this 3,5 cyclic AMP is around, is bioavailable in the cell, then both the mast cell inhibition and the inhibition of smooth muscle cell contraction occurs. So to increase cyclic AMP, you can give somebody a beta-2 agonist or some sort of adrenergic agonist like albuterol, increases cyclic AMP production. Another way to maintain cyclic AMP is to prevent its breakdown. And so that's what phosphodiesterase inhibitors do, because phosphodiesterase is this molecule that breaks down cyclic AMP into 5' AMP. Theophylline increases cyclic AMP production. We don't think it's a true phosphodiesterase inhibitor, but it used to be classified like that. And also milrinone and amrinone are typically referred to as phosphodiesterase inhibitors that will prevent the breakdown of 3,5 cyclic AMP. And then again, Atrovent, ipratropium bromide, is anticholinergic. It reduces cholinergic signaling, decrease mucus production, and try to help promote sympathetic tone to maintain bronchodilation. So we just went over this albuterol and Atrovent. There's some other forms of beta-2 agonists there. Combination medications that include bronchodilator and anticholinergic. Deal with mucus production. Typically don't give mucolytics chronic saline, people that have bronchoconstriction, because it's probably not a good idea to give things that cause bronchoconstriction to somebody that's experiencing a bronchoconstriction. So we typically refrain from using these. Want to provide anti-inflammatory therapy, that would be like Pulmicort or different corticosteroids. And IgE therapies, oftentimes used, and there's the name of one, Amulzinib. It's an antibody that recognizes IgE, so it's an antibody that recognizes the antibody. There's also leukotriene modifiers, that they're a little bit less effective than corticosteroids, but sometimes they're still given. And again, look back at the pathogenesis slide that I showed you, and you'll see that leukotrienes are on there that are downstream of mast cell degranulation. So giving leukotriene modifiers might provide additional benefit to people that are experiencing asthma exacerbations. And if everything else fails, then intubation and mechanical ventilation while we're dealing with the bronchoconstriction. But again, I would only reserve that to people that are absolutely failing and absolutely require mechanical ventilation. So now I just covered emphysema and asthma, and now I'm going to cover chronic bronchitis, and we'll finish up the lecture. So here's an overall chest x-ray, just a zoomed up x-ray of somebody that has chronic bronchitis. And you can't really see bronchitis on x-ray, so I don't want you guys to get the wrong interpretation of it. This is just a representation of somebody that has bronchitis. And so what is bronchitis? So this would be some sort of airway inflammation because of some sort of virus or some sort of infection, and what that does is that increases the airway resistance because it increases sputum production. Most people have a virus, they have increased sputum production. That can lead to VQs mismatching or hypoxemia. It can also lead to oftentimes these people have a normal diffusion capacity or reserve volume. It's just that the bronchial trees themselves are actually inflamed, and they actually have the lungs actually have a bit more of a normal elastic recoil. However, there's an airflow limitation because the bronchial trees themselves are inflamed and narrowed. Therefore, there's an increase in FEV1 to FVC. Signs and symptoms. These are oftentimes viral mediated. It should be a cough is the most commonly observed symptom. Increased sputum production. It could be clear, yellow, green, even slightly blood tinged. Be careful with that because there are also a number of reasons that can cause blood tinged sputum. Somebody has a fever. Sometimes that can be unusual, but it can occur. It can occur in conjunction with a cough, and that suggests some sort of influenza or some type of pneumonia. General malaise or chest pain, and I stress that it would be pleuritic chest pain as opposed to the substernal chest pain that's apparent in myocardial infarction. But general malaise feeling, general overall tiredness, sore throat, runny or stuffy nose, headache, muscle aches, fatigue, diffuse wheezing or high-pitched continuous sound, use of accessory muscles in severe cases. If it's chronic and happens over a long period of time, it increases pulmonary artery pressure levels and causes right ventricular hypertrophy. Also clubbing of the digits. When I put this on the slide, but I also want to mention that people in the respiratory field typically think of, and there's a lot of people in general that typically refer to, particularly in the critical care settings, as digital clubbing being associated with chronic hypoxemia. But I actually encourage you guys to actually do some homework on digital clubbing. I think what you'll find is actually there are a number of causes of digital clubbing. Many of them are completely unrelated to lung pathologies, physiologies, or chronic hypoxemia. It could actually be related to changes and alterations in pancreatic function, liver function, and issues with that biliary tree. And there's actually a very high association between digital clubbing and cancer, and so I think that's important for you guys to be aware of. But peripheral cyanosis, if the bronchitis gets bad enough. or I'm sorry, the chronic bronchitis gets bad enough. And there could be also underlying bacterial viral infections. Most people have had bronchitis before. Okay, so if you've had a cold, you've had a little bit of chest discomfort, then that's bronchitis. Lab tests would be a complete blood count with differential, some sort of sputum cytology or some sort of sputum sample, a blood culture if there's suspected sepsis that's associated with it, or some sort of bacterial superinfection is suspected. Chest radiograph if the person's elderly, or physical findings suggest pneumonia. Bronchoscopy, we typically don't do these for people that have bronchitis, but if for some reason you suspected a foreign body has been aspired, then bronchoscopy might be suspected. Or if somebody has some other reason that we might suspect those bronchioles to be inflamed, such as some sort of tumor or another chronic disease, then a bronchoscopy might be performed. Influenza tests, spirometry, and laryngoscopy to exclude epiglottitis. This can also be ruled out by a X-ray. So we typically don't do invasive procedures to actually diagnose chronic bronchitis. It's usually just a treatment of the signs and symptoms that are associated with it. The treatment oftentimes includes anti-inflammatories. These could be initially non-steroidal anti-inflammatories. If it gets severe enough, inhaled corticosteroids can be administered for their anti-inflammatory properties. Again, these are nuclear receptors, right? These corticosteroids bind to nuclear receptors and cause changes in chromatin structure that change gene transcription. Sometimes that happens from one dose, and people that are on corticosteroids also tend to gain weight. So that's a risk versus gain that has to be assessed for every situation. The inflamed areas may be swollen and filled with mucus, and that causes obstruction of airflow. So we have both inhaled corticosteroids and oral corticosteroids if the disease etiology is severe enough. I also want to deal with mucus production. Again, I put mucimist and pulmozyme on here, but again, you have to be careful, and the risk versus gain has to be heavily weighed. We usually reserve these for people who don't have a risk of bronchoconstriction. Okay. Deal with this through other means like CPT. So the focus for treating is alleviation of symptoms, cough suppressants, non-steroidal anti-inflammatories, antitussives or expectorants, mucolytics, again, risk versus gain, and oftentimes bronchodilators are administered, albuterol, beta-2 agonists, ipratropium bromide, Atrovent, anticholinergics, and so on and so forth. Also combination medications. And that's it.